Thank you everyone for joining us for today's webinar. Good evening. My name is Dr. Njoroge Susan. I'm an anesthesiologist at Pumwani Maternity Hospital in Kenya. I'm going to be your moderator today. I want to appreciate everyone for joining this webinar today. It's a very interesting webinar on ethical challenges that we face in anesthesia and critical care. I also want to appreciate the KSA webinar organizing team for setting this interesting webinar for us today. Thank you, Reverend Father Dr. Paul Kioko, for being with us today. Thank you for actually preparing this interesting webinar for us. For those who don't know, Dr. Kioko, he is an anesthesiologist by training. He began his career as a medical officer at the Mater Hospital, where he developed an interest in resuscitation and intensive care. He later trained in anesthesia at the University of Nairobi and worked as the in charge of the intensive care unit at Mater Hospital. Following a vocational call to the priesthood, he set aside his medical practice and moved to Rome, where he pursued a doctorate in moral theology. His doctoral thesis explored the ethics of complex medical decisions in the context of cancer care. He was ordained to the priesthood in 2019 and is currently the assistant chaplain at Strathmore School and Kianda School. Thank you, Daktari. You're welcome.
Thank you very much, Dr. Njoroge. I hope everyone can hear me, and a good evening to everyone, all ladies and gentlemen. Definitely, it is a great honor and joy for me to address my colleagues in the anesthesia profession. As Daktari as well said in that introduction, my career path, we could say, has been, I don't know if you want to call it anomalous, but okay, we are, we could say, here as speaking to you basically as an anesthesiologist, but with this added advantage that, well, we have studied ethical issues surrounding, especially medicine, I would put it that way. And I would say, just to begin, is to understand by the mere fact that anesthetists, anesthesiologists are human beings. Therefore, they have to make decisions in life. They have to decide whether to wake up in the morning or to continue sleeping in bed. They have to decide whether they are going to work today or they're going to take the day off. By the mere fact that we are human beings, we have to make decisions. We have to make anesthetic decisions. And because they are free decisions, because they are human decisions, they can either be, we can call them reasonable or unreasonable. In other words, they can be right or wrong, good or bad, depending on how you want to term it. And at the end of the day, that is what ethics is all about. It's the study of the rightness, the wrongness, the reasonableness or the unreasonableness of a human decision. And in this particular case, we're going to talk about anesthetic decisions or critical care decisions in that medical context. Because, well, you could say at the beginning, true, there are some decisions that are pretty straightforward. Really, you don't even need to think whether this is a right or a wrong decision. You have a patient has mild pain, you prescribe paracetamol in the correct dosage. That's a right decision. It's a good decision. It's a reasonable decision. On the other hand, there are occasions in which you might face yourself in difficult situations. You have one ICU bed and you have 6 critical care patients on the floor waiting admission. How do you make the decision, this one and not the other? There is when you realize that, well, the anesthetic or critical care decisions that we might be faced with are not always easy. But unfortunately, they are always right or wrong. There could be more right or more wrong, but they're always either right or wrong. Essentially, a free human action cannot be indifferent. Either it is good or bad, either it is reasonable or unreasonable, either it is right or wrong. Anyway, the rest of this talk precisely is to try and understand those concepts a bit more in depth. And let us see if we can get our outline. Essentially, as you can see, I am going to start off with a few ethical scenarios to put us in the context of what we are speaking about, put it maybe in more tangible, practical terms. Although I would like to emphasize already at the beginning that the aim of this discussion is maybe not so much to go through individual cases and how would you sort out such a particular case and what would you do in this particular instance. Very important questions that have to be addressed, of course. But in a way, what I really want is this second point that I put here, basics of medical ethics. It is to understand what exactly are the ethical principles, what exactly are the basics for you and I to make proper, good, correct, ethical, reasonable decisions. That, I think, is what is most important. And that could be the most important takeaway from this talk. Not necessarily what would I do in this particular case, but what are the skills that I need to acquire in order precisely to make that decision for myself. Because one realizes that the ethicist can never be with you constantly every day. And yet each and every single day, you have to make thousands of decisions. You have to make many decisions. And simply, well, it is, maybe I put it in a different way. When we go through anesthesia training, we are provided with certain basic skills, certain basic knowledge, certain basic skills, which then you put into practice daily in a particular patient with particular circumstances, with particular situations. You cannot have your trainer, your consultant, your teacher with you every single day. The job of the teacher, the job of the consultant is to provide you the basics. Then you're on your own. Then you have to make your decisions on your own. Well, the same with ethics. At the end of the talk, if we have a bit of time, I hope to pass, well, I think we shall have, but a few end-of-life considerations. As Dr. Njorge had mentioned at the beginning, I have an interest in critical care and more so end-of-life considerations, given my background in critical care. And I wanted just to share a few principles, a few considerations about end-of-life. And then, God willing, we shall have some bit of time for question and answer at the end. First scenario. As I said, this is just to put us in the context of what we are going to be discussing. First scenario is of a 40-year-old male with hypoxic brain injury from an anesthetic mishap. The patient is on day, put it 150 in ICU. Patient is vent dependent. Neurological consultation is cautiously optimistic about improvement. However, the relatives are unable to continue supporting their patient financially. And so they request you as the attending doctor to switch off the machines and let us take our relative back home with us. So you're faced with such an ethical conundrum. Should I extubate my patient and let nature take its course? Or should I saddle the relatives with a financial burden that at the end of the day, they might not be able to handle, they might not be able to fulfill? Ethical problem. Second scenario, an 82-year-old female. She's been admitted to the ICU with septic shock, multi-organ failure, post-laparotomy for an intestinal obstruction. She's on maximum inotropic and ventilatory support. In this case, her well-off relatives are pushing for everything to be done. And in fact, they have asked you as the attending critical care physician to immediately authorize air transfer to another facility for their patient to receive experimental therapy. Ethical question. Should, in this case, everything be done? Should I authorize this patient to be transferred to another facility? Third scenario is a patient who is a child undergoing routine tonsillectomy, accidental arterial injury was sustained, unfortunately, during surgery. The ENT surgeon, unfortunately, is unable to control bleeding. Intra-op, you confirm a congenital bleeding disorder. The parents of the child unfortunately refuse to give consent for blood transfusion on religious grounds. Question arises, in this case, intraoperatively, should I overrule parental authority and order the child to be transfused? What should I do? These are the three initial scenarios I just wanted to share with you to help us, in a way, keep them at the back of our minds as we go through the rest of the talk. Remember, as I said at the beginning, the aim of this talk, more than to sort out individual scenarios and give possible solutions, because in each scenario, there could be different solutions. There's not one fixed correct answer in each of these scenarios. And therefore, I think what is most important is for us to get a few basics, and therefore each one of us can then think about it and decide, what if I was faced with this situation, what would I do? And to start us off on this discussion of the medical ethic principles, we want to discuss a few basic principles of medical ethics. And what I want us to do at the beginning is to walk through a few schools of thought of ethics, more specifically bioethics, under which medical ethics also falls. So the idea here is to understand how different people in different moments have tried to lay out certain principles to be able to decide what is the right decision, what is the wrong decision, what is a good decision, what is a bad decision. Now, each one of these schools of thought has got its positive points and its negative points maybe. Of course, there's one school of thought to which I subscribe, because that is the one in which I have been trained, and that is the one that I shall mention at the last, and we shall discuss it a bit more in depth. But to start us off, I wanted to discuss briefly something called principalism. Now, principalism is very favored in the United States of America. It has been championed by two gentlemen, Beauchamp and Childress, two bioethicists. And this is a theory or a school of thought that developed in the 1970s. It was first articulated by a certain national government organization of the United States called the National Commission for the Protection of Human Subjects of Biomedical and Behavioral Research. And they published a certain report called the Belmont Report, which specified 3 of these 4 principles. And later, in 1979, Beauchamp and Childress produced their famous textbook called The Principles of Biomedical Ethics. 1979 was the first edition. Currently, I think it should be around the 7th or 8th edition. Now, the 4 principles or 4 bioethical principles are essentially autonomy, meaning whenever you're making a decision, you have to bear these 4 principles in mind. Number 1 is the autonomy of your patient. So respect their wishes, respect the decision-making capacity of an autonomous patient. What do you want? What is your feeling? So autonomy is important. Consent, in other words, for the patient. Secondly, non-maleficence, meaning whatever decision you make in terms of treating a patient should not cause harm. It should not cause more harm than good that is supposed to provide. And that brings us to the third point, which is beneficence. Precisely, it should provide benefit. It shouldn't be ambivalent. If your medication or your decision is not going to improve the fate of the patient, then it is just a burden, a waste of time. Don't do it. Okay, so the first point, don't cause harm, but at least try and help your patient. Try and do something that will help that patient. Fine. And the fourth principle is justice, meaning that within the context of that decision that you have made, one has to bear in mind an overall good, okay, an overall justice in terms of how much money is being used, what are the risks and benefits, what are the distribution of resources that are being used in this particular patient. So autonomy, non-maleficence, beneficence, justice. It is a good starting point for sure, because, well, we shall see later on, but in a way, most most ethical decisions, precisely, one needs a certain benchmark, a certain principle from which then you can derive particular cases to be solved. Okay, so it is good in the sense that it sets out a certain number of principles. Unfortunately, or maybe the negative aspect is, maybe it is not so obvious, but this thought point of view, the physician as an ethical agent is sidelined. In a certain sense, the physician as someone who also has a certain responsibility in that particular ethical decision is not as important as the patient. And then reducing the whole of life simply to 4 principles, again, one realizes that life is very rich. There are many instances in which these 4 principles would apply, but there are many other principles, or many other issues that one would like to take into account. Culture, end of life issues for certain cultures, etc., etc. That might not be totally captured with these 4 principles, but it is definitely a good starting point. The second school of thought is what is called the Utilitarian Consequentialism. Now, this was championed in the 18th, 19th century by some philosophers called Jeremy Bentham, John Stuart Mill. Essentially, what they say is that in any way it's happiness and pleasure for the person, that is the right decision. And a wrong decision is that which produces unhappiness or pain. Their basic idea is that decisions should be evaluated solely on the consequences. If I have a good outcome, it's a good decision. If I have a bad outcome, it's a bad decision. Now, the main drawback for this theory is that with this, you canonize what we call that idea of the end justifying the means. So if the end is simply a good outcome, therefore I can justify any means to achieve that good outcome. Unfortunately, there are certain means that are not good in and of themselves. Okay. Okay, maybe this doesn't apply so much, but imagine you're intubating a patient. Okay, so the end of that action is to have a tube, an endotracheal tube within the trachea. Okay, now if you take this theory strictly face value, it means I don't care how that tube enters into the trachea, so long as it has entered into the trachea, it was a good decision. Okay. And as I said, because of that, you can do a lot of damage, because you might say, well, fine, the easiest for me in this particular case is just to do a tracheostomy and I put in my tube. Okay, fine. But have you thought of other things before you get to your tracheostomy? All right. So, and if one says that the end justifies the means, there are many times that you will get into decisions that become quite problematic, or you might choose means that later on become problematic. Also to remember that patients are human beings. They cannot be treated as robots in a balance of exactly how much is good, how much is happiness, how much is pleasure. Patients are human beings, and there are many, many, many other issues that are surrounding the decisions that one has to make anesthetically with them. Okay, the third, we could say, school of thought is what we call deontological principles. Now, this was championed by a philosopher called Immanuel Kant in the 18th century. And his main theory is that actions are right or wrong, not so much depending on the consequences, but on whether they fulfill your duty or not, whether they adhere to pre-established rules or guidelines. So if my decision follows certain guidelines that have already been published, it is a right decision. Normally, these guidelines would be expressed in some form of a professional code of conduct. And here we understand perfectly well, because we do have deontological principles. We do have a professional code of conduct. The Americans have the American Medical Code of Ethics. In Kenya, we have the Code of Professional Conduct and Discipline. I think it should be around the 6th edition, if I'm not wrong. And then it is also brought down to the anesthetic level with the National Anesthesia Guidelines of 2016. So they are good. We do need deontological principles. We need certain guidelines. We need certain principles to be able to make certain decisions. But remember, these are precisely guidelines, okay? They are not prescriptions for each and every single situation in which I will find myself. And you just need to go to the national guidelines, national anesthesia guidelines to realize that, well, it is, I forget how many pages, but let's put it, it's like 50 pages. Okay. If you count all the patients that you're going to see throughout your anesthetic career, you realize that those are very many patients. And each one of those patients might have certain situations, circumstances, combination of disease, combination of relatives, combination of financial background, whatever, that might not be fully captured in a simple professional code of conduct. And that is maybe one of the major drawbacks of deontological principles, that because human life is by definition so rich, you can never fully quantify and specify every single scenario possible that a doctor will face. Otherwise, you get into problems of casuistry. This case and this case and that case and the other case, it's impossible. True, we need principles, but they are guidelines. Now, the main problem is, how do I apply principles? How do I apply all these three things that we have spoken about of the first one, the deontological principles, the utilitarian, and the principalism of Beauchamp and Childress? How do we apply those in the particular case? Good. And that is now where I would like to maybe dwell a bit more. And that is on the last school. As you can guess already, this is where I tend to focus more, because this is where we were trained in, at least in where I went to do training. And it is in something we call virtue ethics. And this is a way of understanding how to apply in each and every single particular case the reason, the good, the rightness of the principles, of the basics to this particular case. And I would like to start maybe just with a bit of history. This theory, well, it's not, well, it's a theory, school of thought, has gained, we could call it ascendancy, especially in Europe, championed, maybe the first major author, at least in modern times, is a gentleman, a professor called Alistair Mcintyre. He, a professor of philosophy in the United States, has taught in Duke University, has taught in Notre Dame, has taught in Vanderbilt, Boston University. Anyway, he wrote a very influential book in 1981 called After Ethics, After Virtue. And in that he proposed precisely to rediscover, to, in a certain sense, go back to the virtue ethics of the ancient Greeks. And that he says, and it is precisely what I want to bring out, that this can give us precisely a way forward in applying principles to particular situations. And it all depends, or it all began, or it all begins with this concept called Eudaimonia, which is a Greek word meaning happiness. And the ancient Greeks had this, how could you call it, preoccupation with what makes a man happy. There were different theories. The Stoics, who are a group of philosophers, felt that happiness is because of perfectly controlling your emotion. Showing no emotion whatsoever makes you happy. And even now we still have the English of being stoic, that you don't show any emotion, fine. Then there were other gentlemen called Epicureans who believe that happiness is due to unlimited pleasure that will give you happiness. Of course, recognizing that happiness is not something that you get directly, but it is something that you get as a result of doing something. Now, at the end of it, we have a learned gentleman called Aristotle. I'm sure all of us may have heard of Aristotle. Aristotle, who is one of the greatest Greek philosophers, precisely is the one who put it down in a way that is understandable and makes sense. And he argued the following, that it is actually the good life that makes people happy, ultimately. And what is the good life? The good life is a life that is governed by reason, by logic, by reason. Fully controlled by reason is what makes a person happy. A fully reasonable life is what makes a person happy. And here we're talking about reason, not just theoretical reason, but what we call practical reason, meaning in the things, in the actions that I do, if all the actions that I perform are reasonable, at the end of my life, I shall be a happy person. And therefore they ask themselves, what makes an action reasonable as opposed to being unreasonable? And here it is very important to understand that reasonable means the right action, means therefore the good action. And therefore an unreasonable action is a wrong action, it is a bad action. By reflecting on human actions, they arrive to the conclusion that good actions, reasonable actions, are essentially, we could say, guided by what they called arete. Arete was translated into Latin as virtutis and into English as virtue. Basically what they're saying is that for any action to be reasonable, it has to be virtuous. It has to fall within 4 virtues, which is the basic 4 that they grouped all human actions into. Good, reasonable human actions into, as in temperance, fortitude, justice, and prudence. Let me put it very simply. What they're saying and what we are saying is that for you to do or for you to perform a reasonable action, it must be temperate, it must be prudent, it must be just, it must be fortitudinous, if there's such a word. And an unreasonable one is intemperate, unjust, imprudent, unfortitudinous. And maybe here I just need to give a bit of a basic example. You're in traffic and someone overlaps you on the left-hand side. There's traffic, everyone is in line and somebody is overlapping on the left-hand side. Immediately, innately, without anyone telling you, you feel this fellow is being unreasonable. Why? Because he's being unjust. Another example, you are all invited to a dinner somewhere. And then there's one fellow who is eating all the food that is on that table. Immediately you think this person is being unreasonable. Why? Because that person is being intemperate. You go to a government office and somebody asks you for a bribe. Immediately, this person is being unreasonable. Why? Precisely because he's lacking justice, etc., and so on. One then begins to understand precisely this idea that reasonable actions are virtuous actions. They are directed, they are guided by the virtues that every human being has. We could say the seeds of those virtues are in us innately. No one needs to tell you that overtaking on the left is something. You just know this is wrong. Or somebody cheating you, or somebody stealing from you. You just know that these things are not reasonable. Now, I want us to take the next step forward. And that is that precisely every anesthetic decision, every anesthetic action, in a certain sense, also must be reasonable. Not just technically correct, but reasonable at the same time, meaning guided by one of these virtues. Maybe, okay, I don't want to go too deep into all this because maybe it is not so, but anyway, briefly, if you don't get it, no problem. But anyway, temperance is that virtue that controls the actions that give man pleasure, eating, sleeping, drinking. Fortitude is that virtue that controls or that guides the actions that are difficult, arduous goods. So for instance, you have to push yourself to study. You have to wake up at midnight to see a patient. You have to push yourself. Fortitude is that virtue that will tell you when that is a reasonable action or not. Justice is that virtue which we could say guides any action that has to do with somebody else. How much am I going to charge my patient? How much am I going to ask? How much am I going to give? Justice. Prudence is the last one, which we shall go in a bit in details later on, is the one that guides the 3 others. Okay, let us end it at that. A few points maybe to remember that there's a difference between a human act, which is what we have been discussing, a free human act, which is something I decide to do, as opposed to an act of man. Vegetative functions, a heart beating has no ethical connotation because I have no control over it. I have no free decision over deciding my heart rate. It just happens automatically, okay, or digestion, okay, etc. The other distinction, maybe just talks briefly about mistakes. Mistakes can be technically vincible, meaning we make a mistake because of poor preparation. Or mistakes can be invincible, meaning we make a mistake because we just didn't know. Okay, we just made a mistake, we didn't know. I will not go further into that. It has its own development, but we'll leave it at that for the time being. Okay. Second ideas, or basically going a bit deeper into this idea of virtue ethics. Every human action leaves a mark on a person. Very important. What do I mean by that? If you, for instance, habitually, you steal today something, you steal 10 bob. Tomorrow you steal 20 bob. The other day you slowly take up the habit of stealing. What happens is that at the end of time, you become identified with that action. People begin to call you the thief. It also works in the positive sense. So for instance, if every day I arrive punctually at class, one day, the next day, the next day, the next day, people identify you with that action, that punctual person, okay? Now, take that to the maximum. A person is the sum action or the sum total of his habitual actions. He's generous, or he's honest, or he's a thief, or he's dishonest, or he's lazy, etc., etc. Now, every medical decision, because it is a human action, also contributes to this same idea, of being characterized or being part of the character of the anesthetist. So every time you overcharge a patient, for instance, okay, that would be unjust. And therefore, each and every overcharging is an unjust action that leaves a mark in you as an unjust person. At the end of your career, this is that unjust anesthetist. Okay, and so on and so forth. As we said at the beginning, there's some medical anesthetic decisions that are so basic that it doesn't change too much. Prescribing paracetamol, fine. But we realize that there's some that precisely leave a mark on us. And that is where now ethics becomes important. And therefore, this question is therefore important. What kind of anesthetist should one always strive to be? So the question is not so much, what can I do or not do in this situation? Rather, what do I want to be as a human being, as a person, as an anesthetist at the end of my career? Do I want to be a prudent anesthetist, a temperate anesthetist, a just anesthetist, a fortitudinous, meaning all the virtues put together? Okay. And that is what it means when we talk about virtue ethics. And that is what it means also to be looking at the decision from the inside. That is a first person perspective. Most ethical discussions, etc., tend to be from the third person, looking from the outside. You should do this, you should apply these principles, you should, very good. But the point is that at the end of the day, who makes that decision? It is that anesthetist facing that patient in that room. It could be the ICU, it could be the operating theater. And you have to apply all the principles or the technical preparation that you have had, and you as a person make that decision, knowing that that decision will leave a mark on you as a person, okay? Because you could say, but look, a right decision is simply the technically correct decision. Not always. Scenario, imagine you technically fix a central line perfectly well. Not a drop of blood, it's in exactly the correct position, no side, no problem, no complications, very good. But then you charge that patient 100,000. And you ask yourself, have I been a good anesthetist? Was a good anesthetist simply in fixing that central line very well? Or is it in a global, greater, from a greater global point of view? That is, I think, what is important to think about. Good. I would like to briefly go through some points about making prudent medical decisions. Remembering, as we said, that prudence is that virtue that applies the universal, the principles, to the particular. This patient, in this theater, at this time, with this clinical scenario, etc., etc. Okay. I would have liked to go a bit into the nature of medicine and what it is, but maybe that is not so important at this point. Simply to remember that for decisions to be good, they must be aligned towards the end of that activity. In the case of medical activity, medicine as a human activity, we have a long-term goal, long-term end, which is health, short-term goals, which is the cure of illness, the relief of pain, or the containment of disability. But the immediate, that which you have to do when you're deciding, I'm fixing a brannula, I'm going to induce with propofol, I'm going to intubate this patient. At that moment, you have to make an immediate decision, which must be technically correct, but at the same time, morally good for it to be a totally good decision, okay? There are 8 parts of prudence, which we shall run through briefly. And I've translated them into maybe medical words because, well, the 8 parts of prudence are in general. They apply to everybody, not just medical people, but in general. But I've applied them here specifically to medicine to help bring it close. So the first is clinical experience. I guess here we understand it pretty well. Clinical experience is that memory that you have of past clinical situations and events, and you use that clinical experience to help you make a decision in the here and now. Remember, all these are parts of prudence. So clinical experience is part of being prudent, having experience. And it helps you to make decisions, especially in moments when you have a lot of emotions, we could say emotional reactions surrounding that situation. For instance, I don't know, imagine you have a difficult intubation scenario, okay? There are a lot of emotions going on, okay? The saturations are going down, the alarms are going off, the nurse is panicking, people are panicking, the patient is going. You need clinical experience to know, what do I need to do here and now, based on previous difficult intubation scenarios. Second, clinical intuition, which means to be that ability to grasp fundamental aspects of a certain situation, the ABCs of resuscitation, okay? It is the ability to prioritize what comes first. Makes no sense to be struggling for a line when your airway is compromised. That is clinical intuition. Quickly, what is the first thing that needs to be done? Docility. This is part of prudence in which we allow ourselves to be taught. Maybe this is the whole part of going through training. We need to be taught. We need to learn how to learn. We need to learn when to ask for advice. We need to learn when a second opinion should be sought. We are open to being corrected. That is part of being prudent. And that will help you to make a correct decision in the here and now. Sagacity is spot decisions when we have to quickly decide this is ventricular tachycardia and I need to defibrillate or whatever it might be. So quickly, rapidly grasp what needs to be done and act upon it. Clinical logic or reason means to arrive at the correct conclusion from available data. Integrate physical exam, lab, the particulars of the patient, the place that you are, etc. Logically, step by step. Clinical foresight, which is that aspect of prudence that helps you foresee future consequences. If I do this, what will happen in the future? And don't be limited to the immediate. Think of the different things that could go wrong if I choose this particular, I don't know, mode of giving anesthesia. Fine, it could be general, it could be local, it could be regional. What are the future consequences? That is clinical foresight. Clinical circumstances means to take into account not just the physical patient, but think of them existentially. They have parents, they have children, they have a family, they have a future, they have a past, they're employed, take that all into account. And finally, caution, meaning authenticate information. Don't take everything for granted, okay? Don't take everything for granted. Good. Remember, in all this, at the bottom of it, if you remember, we said that the right decision has to be technically correct, means that you have prepared yourself technically, correctly, properly. You have exercised your residencies, etc. You've gained all your skills. And then finally, prudence helps you in this moment to make the right decision with this patient in this particular circumstance. Good. I think, yeah, basically what I really wanted to say has been said in terms of the basic ideas, principles, and maybe by now you've understood that I really wanted to emphasize this idea of virtues, which helps one make a technically correct as well as a morally good decision at that particular moment, okay? And these are things you could ask, how do I learn? At the end of the day, we learn these things in life. We make mistakes and we learn from those mistakes. But it's also part of growing up. As we grow up, we are told what is right, what is wrong, and we apply that also to our profession. And that is the whole importance of keeping our minds open to learning, to asking for advice and improving ourselves in that. Okay. I wanted just to run briefly through a few end-of-life issues, which can maybe help us to realize that medicine is not just, again, as I said, technically correct, but it also has many other aspects, moral, that are important in each case. Okay. Briefly here, what I wanted to discuss is something we call the principle of therapeutic proportionality. This basically applies at end of care, end of life, sorry. And there are two extremes into which we can fall. On one side, on the left-hand side, is what we can call euthanasia by omission. We don't do what we are meant to do. And on the other hand, we can be therapeutically obstinate. We try and overdo things, okay? Then there's a gray area in between, which we can call optional. Now, the upper arrows refer to the patient. The lower arrows refer to the physician. It is the patient to decide, or the patient to realize that this is ordinary care, this is extraordinary care. It is the physician to decide this is proportionate care, this is disproportionate care. We shall go through this a bit in detail. But the point being that it is ethical to do anything that is proportionate to a patient, proportionate care, to provide proportionate care, unless, of course, we go on to the extreme of stopping all care when it should be given. What is unethical is to give disproportionate care. However, what is optional is what is for that patient extraordinary, but for the physician, for him, it is proportionate. As I said, we shall see a bit what this means. Ordinary, remember here we're speaking about the patient. So ordinary means of care should be things that offer hope of benefit. It should be useful. So for instance, yeah, offers hope of benefit. Let's just leave it at that. Or maybe, maybe just to go back to this and explain a bit. For a Kenyan patient, let's put ourselves in the Kenyan context. What is ordinary care for a patient? We would say the basics, food and water in a ward. That is ordinary care, food and water, and maybe if you want to put it that way, basic nursing care. Okay. What would be extraordinary? Mechanical ventilation. Extraordinary because not every Kenyan has equal access to mechanical ventilation. So for an ordinary Kenyan, we could say mechanical ventilation could be considered extraordinary. Okay, we come to the physician. What is proportionate care? Well, proportionate care would be to do the best, how could we say, the normal care that we give. Let me not go beyond that. So proportionate care that would be extraordinary would be, for instance, mechanical ventilation post-thoracic surgery. So it's proportionate because we expect good outcomes. It could be extraordinary for the patient because, well, it is just not everybody who can get mechanical ventilation post-op, but it is still proportionate. It is ethical, okay? But it is optional in that sense that in extreme cases, you don't have mechanical ventilation, fine, you try your best, okay? Disproportionate would be, for instance, mechanical ventilation for an end-stage metastatic cancer. So it is disproportionate to the outcomes that are expected in this case, and that would be unethical to intubate a patient who has end-stage metastatic cancer with no hope of survival, that patient should not be intubated. Should be provided with ordinary care, for sure, because otherwise we will fall into euthanasia by omission. But we should not intubate as a general rule. Okay, good. Ordinary means of care would be those that offer hope of benefit. We can call them the normal standards of care, not too difficult, simple. But let me just put here, social personal status, meaning that the ordinary means of care for the president of a country are not necessarily the same ordinary means of care for a patient from a slum. Why is that? For the simple reason of what we call the greater good or the common good. In case of war, maybe it is easier to think about it. In case of war, what you want to do is to keep that president of yours or that general of yours alive at all costs. Because if you lose your president, you lose your general, the whole country succumbs, okay? So ordinary means of care depends on the social status, depends on the personal status. The ordinary care for somebody who has 1 billion Kenya shillings in the bank might not be exactly the same as the ordinary means of care for somebody who has no money in the bank. Okay. That is also debatable at a different level, but I just leave it at that. Okay. Remember that these factors have both objective, subjective elements, which we've just elicited somehow. A patient who refuses ordinary means would commit suicide. A patient who refuses to eat and drink would be committing suicide. And a physician is obliged to offer food and drink. Okay. And that is why if we withhold them, we might be committing an injustice. We are taking unjustly away the life of a patient. Okay, extraordinary means of care. Remember, we are still on the side of the patient. Something that is impossible, okay? So for instance, for a patient, it would be impossible for him to go to another country to receive appropriate care. That would be extraordinary means of care. The patient is allowed to refuse that, and that is ethical. A patient can refuse, say, no, you have referred me to another country, I cannot go, it is impossible for me. Or the effort is too great, okay? In terms of the effort that will be required to achieve that therapy is too great. Again, the patient can ethically say no. If it is too painful for the patient, we remember in the old days before anesthesia came, amputations would be done under alcohol, if you put it that way. Yeah, you give a patient alcohol and then you do the amputation. A patient in that situation is perfectly ethically allowed to say, no, I do not want this operation. Or if it is too expensive, we have a patient in an ICU maybe, and the relatives want to sell all their ancestral land in order to keep their shosho in the ICU. That would be extraordinary. And they're perfectly within their means to say, no, we have reached the end. We can call it quits. We can call it an end. And that is still ethical because it is something extraordinary for them. Finally, it could cause repugnance and fear. Maybe it's not so much, but well, some patients, for instance, refuse to lose their limbs. And again, that could be considered extraordinary and they are ethically allowed to say no. Fine. Proportionate, disproportionate from the point of view of the side of the physician. Basically, I would just say proportionate medical care is that in which we have a medical certainty of achieving a predetermined health objective, taking into account the available resources that we have, expecting good outcomes, avoiding negative foreseeable risks, and that there are real alternative options that have been studied. Anything that is proportionate would be ethical, okay? Anything disproportionate would be unethical. Just to remind ourselves of that. So going again, the patient is ordinary care, extraordinary care, okay? They are allowed ethically to refuse extraordinary care. The physician should always provide proportionate care, remembering that in some cases, his proportionate care may be ethically refused by a patient who considers it extraordinary. A physician should never provide disproportionate care. And if we go onto the extreme side of removing all proportionate, all ordinary care, we also commit an injustice. Okay. With that, I would like to end briefly our talk, re-emphasizing the basics that we have gone through. Maybe we've been a bit general, but that was the aim. It was just to touch each one of those things that we have spoken about. Can take a whole lecture. But the basic idea I wanted to drive home is that to be a good anesthetist, one must make good decisions. To make good decisions, one must be guided by prudence. And to be prudent, one must acquire the virtues. In other words, I want to emphasize that to be a good anesthetist is not simply to be technically competent. It means that one also has to be prudent. One has to be virtuous. One has to make prudent medical anesthetic decisions. And whether we like it or not, those leave a mark on us. They either make us good or not good at the end of the day. And I think I would like to leave it at that. And maybe if there are any questions, additions, subtractions, clarifications, or whatever else people might like to contribute. Thank you very much for listening.
Thank you very much, Dr. Reverend Paul Kioko, for that very insightful topic. We have 2 questions in the chat box. Just a reminder, if you have a question, you kindly post it in the chat box, then Father is going to answer them one by one. So I'm going to start with the first question. The question is, in the discussion of decision making, does personality play a role in ethical decision making? For example, someone who is timid or very reserved may make a wrong anesthetic decision because he cannot stand up to a domineering surgeon.
Very good. It is true, personality might influence one's decisions, but again, that we could say takes us back to this whole idea of the virtues. None of us is born perfect. All of us have tendencies one way or another. How could I put it this way? Some people are just, I wouldn't want to call it born lazy, but you know what I mean. That people just find hard work difficult. Okay, they need to recognize their weakness and make a special effort to overcome that weakness by practicing actions in the opposite side. Okay, so if you are generally speaking a lazy person, well, you have to recognize it, number one, that I'm lazy, then come up with a timetable and push yourself every day to follow that timetable. So the first day, the second day, the third day, 1 year, 2 years, with time, precisely, you acquire the virtue of hard work, of order. That is how we acquire virtues, by a dint of trying it over and over and over and over again. To be punctual, to be habitually punctual, there's at the beginning you're not, and then you have to make a decision. Okay, I want to be punctual, and then you try again and again until it becomes part of you. You become a punctual anesthetist. Okay, so if I recognize that I'm a timid anesthetist, I recognize that that is the defect that I might have. I need to make a decision rationally, reasonably, to say, okay, fine. Anytime I have a domineering surgeon, I need to do 1, 2, 3. And you practice it once, and a second time, and a third time. And at the beginning, most likely you will not manage. But if you go at it enough times, you will acquire that virtue. You might never be able to be perfect. No one is perfect by definition, but at least you will be on the way to becoming a better anesthetist by making that specific, reasonable, logical, conscious effort to acquire that virtue of standing up for your decision, saying, no, Daktari, we need to stop now. No, Daktari, stop doing what you're doing, etc. Okay. Remember what we said, all those points about prudence. And one of them that could be important in this case, for instance, is advice. So you need to ask a senior colleague, how do I handle this particular surgeon who always intimidates me? So that senior colleague will give you some reasons, some ways of handling that surgeon, which you then again consciously try to put into practice once and a second time and a third time, etc. Maybe in the beginning you would need precisely your consultant to be with you, or your senior colleague to be with you, or somebody else to be with you, to help you make that decision, to help you stand up to that surgeon. And as you go along, you will acquire it. Okay? Good point.
Thank you. The next question is, what may seem to be a right or ethical action may not be the same to other parties. How does one reconcile the varied definitions of ethical in patient care? This is in the concept of the many malpractice cases in which colleagues are called upon to give their opinion.
Very good. And precisely, I think that was the reason we spent a bit of time with this idea of virtue ethics, because what we want to emphasize is that an ethical decision is a reasonable decision, meaning it is reasonable, logical. And that cuts across religion, cuts across culture, cuts across, okay. The problem maybe could be to say, okay, how do we decide what is reasonable, what is logical, what is reasonable? And that is why it is good maybe to go as far back as possible. And in that sense to say, well, something that is as universal as possible. And that is why we in general use the Greek philosophers, because in a certain sense, they are universal in terms of Western thought, at least. Now, but as I was also pointing out in one of those examples, this reasonableness is part of us as being human beings. And therefore, each and every single human being, if he has time enough and freedom enough to think enough, he will come to this precise same conclusion, that the reasonable actions are precisely the virtuous actions, are precisely the good actions, okay? So an ethical or a right decision is that which is just, which is temperate, which is prudent, okay? And as we said, it is almost innate. You see somebody doing something that is unjust, and you know immediately this is unjust, this is not right, this is illogical, this is unreasonable, okay? Cheating a patient, overcharging, cheating in exams, etc., etc. We understand. It is actually, maybe you could almost say you don't need to be told. You just know that this is not right. Why? Because it is precisely part of being reasonable. To be virtuous is something reasonable. To be full of vice is unreasonable. And that is, I could say, maybe the most important insight with this school of thought of virtue ethics. It is just a matter of using our mind, using our brain, using our logic, using our reason to arrive at the correct decisions, to correct at the right decisions. Now, having said that, remember that many times we use what we had called deontological principles. We use codes of professional ethics, which we then try to apply in certain concrete situations. We've mentioned that we should always use the virtues to help us do that. But unfortunately, at times, those who come up with these deontological principles might not actually have put the most logical guideline, because they are human beings and they could be either simply erroneous, made a mistake, or they could have been influenced by certain lobby groups or by certain monetary concerns, etc., etc. Okay. So at the end of the day, it still comes down to you as the individual anesthetist, guided by your prudence, guided by your virtues, to decide what is the technically correct and morally good decision in this case, in this with this patient, in these circumstances. Because anyway, let me just stop it at that. But emphasize once again that the right decision is the logical decision. It's a reasonable decision, the good decision.
Thank you. Our third question, how do we deal with lack of teamwork in operating room? For example, a surgeon wants his ideas to be primary in post-op care without taking the anesthesiologist input.
Yes, and team dynamics are always difficult. At the end of the day, one has to always be guided by justice, what is due to the patient, what is the greater good of the patient. One has to take into account the dynamics of each person in the team. And at the end of the day, one needs to have a team leader who can understand the strengths and the defects of each team player. I think it's also important, maybe we have been talking about this a bit theoretically, but to remember, we are all human beings. Each anesthetist is a human being. No one is perfect. And the best way of handling a team be listen to more or less, how can we go around certain characters, etc. I will leave it at that. I will not go into maybe more specifics because each team has to be looked at individually differently. But at the end of the day, it is a matter of knowing human beings and knowing their characters and knowing how to handle each one differently.
Thank you. For those of the participants who are requesting for a presentation, this webinar is being recorded and it will be uploaded at the KSA website, the YouTube channel, and all social media platforms by tomorrow. Our final question is, would it be prudent to transfuse a child in the scenario that you gave, whose parents would not have consented to blood transfusion on religious grounds?
Yes. As I said, I try to avoid as much as possible giving direct yes or no, because it depends on the situation, depends on the patient, depends on the doctor, depends on the clinical, what is the level of blood that has been lost, etc., etc. Okay, but the general, and I think actually it's even, if I'm not wrong, it's even captured in the National Anesthesia Guidelines, is that in cases of minors and anesthesia, the best interests of the minor normally take precedence. So in this case, though it is quite controversial and you need to check very carefully with a legal person, but you might be able to get away with transfusing that, that patient. Remember, okay, you have to look at it in different ways, and that is why the importance of prudence. What is the best way of going about it? Do I try to talk to the parents? Do I simply ignore them? Do I try to bring in others? Do I involve the legal? Do I involve the hospital? Do I simply keep quiet, transfuse, and hope no one? Okay, so all that will be guided by prudence, which then, of course, takes into account the particular patient, the particular circumstances, the parents themselves, the age of the patient, the emergency of the situation, etc. Okay, and then, of course, the code of professional conduct. Am I supported by that code of professional conduct? Okay, and then you make that final decision. But as a general rule, I would say fine. The good of the patient, the good of the minor in this particular case, might outweigh the religious feelings of the parents.
All right. Thank you very much, Dr. At this point, I would like to invite Dr. Chokwe for a few comments.
Good evening. Thank you very much, Dr. Kioko, for your talk and this discussion we've had before, and everybody else who's been able to attend this particular discussion on ethics. He has dwelt significantly on the care of patients and what we have considered for a long period of time a point of conflict with the rest of the caregivers in the institution. There are other aspects which might not have been covered in this particular talk, which we may have to give consideration going forward in everything that we're doing. Institutions themselves and the law have protected and created a wall or symptom of making sure whatever happens to the patients, either good or bad, nothing untoward comes to them. On the other hand, the caregiver is also an important person as far as ethical practice and outcomes of patients are concerned. We have daily challenges as anesthesiologists, production pressure, which has seen significant number of anesthesiologists quit in areas where they're the primary caregivers with no secondary assistance. Our interactions with industry, which puts us pressure to use certain specific products, promotions, and the likes, including things that might not necessarily be functional. And those who have come across some of these have realized in certain situations, you actually tell some of those people who are pushing certain products that if it was at the end of the night and it is them who would have to utilize some of these products like medications, would they accept admission of such therapy? The safety care initiatives that we have and people who are pushing politics in relationship to anesthetic care, which has changed from just a practice to a science and professional conduct, We have things that are happening in our own society locally. You've all come across the ESM ketamine scenario that has been happening. The issue of crash courses where people think people can learn anesthesia in 3 months. Questions of task shifting, teaching other people who are not medically inclined, for example, to give anesthesia. The latest COVID scenario in the last 1 year, you had people who were inventing ventilators, none of which have seen the light of day. We used to call them the Ambu-bag squeezers. Where are we with all those things? We must put it at the end of the day that it is our obligation to own the advancement of the profession and create advocacy as well. Most significantly is the issue of the impaired anesthesiologist. Where do we place ourselves in this scenario? There could be our seniors, there could be our juniors, there could be our contemporaries. How do they affect the safety and outcomes of the procedures that we are handling in the clinical scenarios? How do we rehabilitate them? And how do we give them an alternative pathway in professional production? There is lots of things if you go into the history of anesthesia and its development, in which case certain anesthesiologists fell off from the main pathway of clinical production. They went into publication, equipment development, and even drug synthesis, for which they have helped us develop. So if somebody falls off the clinical pathways because these pressures are too much, it does not mean it's the end of the career. And when we rehabilitate these people, how do we put them back into clinical practice without necessarily stigmatizing them? Dr. Kioko has covered a significant bit of this, and I hope the message is home for everybody who has attended tonight. Thank you. Susan?
Thank you very much, Dr. Chokwe. Just a reminder, the CPD points will be sent to the emails, and the certificates for the nurses and the clinical officers, as well as our non-local participants, will be also sent to your email. Our next CME will be on the 16th of May, and the communication will also be sent through the emails. Thank you very much, Dr. Kioko, for such an informative talk. And I think for the take home is what kind of an anesthetist should we strive to be at the end of our career? And for every anesthetic action that we do, it should be reasonable and guided by prudence. Thank you very much, everyone, for attending.
Susan, just
Yes.
a minute.
Yes.
Dr. Munyoro wanted to say something. She's our specialist in palliative and pain care, so probably we allow her to say something.
Oh,
Dr.
all right,
Munyoro,
sorry.
you're still here?
Proceed, Dr. Munyoro. I hadn't seen you had raised your hand.
Thank you. Can you hear me?
Yes, we can.
When you talk about the impaired anesthetist, wouldn't it make some headway if you did psychological testing before people get into anesthesia? Because most people who get into problems, you can tell they will have problems long before they join anesthesia.
I guess that's for Dr. Chokwe to please respond.
Yes, thank you for that question, Dr. Munyoro. You realize how anesthesia has transformed over the years. Previously, it was the leftover specialist. That means everybody who failed to probably join neurosurgery or whatever found themselves in anesthesia because there was a desperate situation where people wanted to be. Today, the number of applicants far outstrip the number of positions that we have for training. And one of the hardest questions at the anesthesia interview is actually, why do you want to do anesthesia? And the answer to that particular question gives a lot of guidance to what we can do with the kind of people who come in. And as we go through the assessments and evaluation of the people in anesthesia through the years, effective mentorship and guidance gives us direction as to which people we would want to actually still go ahead and do anesthesia. A challenge comes to us because other people think we might be too strict in the anesthesia training. And the question again posed to them is, would the person you think is qualified as an anesthesiologist, any hint of hesitance then gives us that particular answer as to how far we can go with these impaired people. Thank you.
So thank you everyone for participating, and see you next time. Bye and good night.